Today's topic that I have chosen diabetic foot. I have chosen because diabetic foot is a very common complaint seen by the diabetic population when you visit the hospital, either in OPD or in the wards. And they are a lot of problems they are facing, including amputation. So let us understand the diabetic foot in details so that the treatment protocol will be established very nicely, and the concept of the diabetic foot ulcer you must understand. Also, it is a common disease that can be asked in the examination as either as an OSCE session or in the MEQ, and certainly in short and long cases. So let us start the diabetic foot. What is the definition of the diabetic foot? It is a disease complex that can develop in the skin, muscles, or the bones of the foot. And the reason for its development is there is either the nerve damage or there is a poor circulation. There may be deformity in the foot and there is an infection. Remember, the diabetic foot is to be taken very seriously when the patient presents even for a minor ulcer. Why? Remember, the problem of the diabetic foot ulcers, it is the most common cause of hospitalization in diabetic patients. Diabetic patients are usually 10 times more likely to have soft tissue infections. Remember, every 30 seconds, a lower limb is lost somewhere in the world because of diabetes. Also to be taken into consideration is the diabetic foot ulcers are responsible for 5 to 10% of the cases of major or minor amputations, and the risk of amputation of the lower limb is almost 20% higher in the diabetic population. And there is still gap between what is known about the diabetic foot and what is really done to them. Diabetic foot and its orthopedic complications are following. It causes delayed wound healing, it causes ulcer recurrence, it causes Charcot arthropathy, it causes osteomyelitis, and the worst is the gangrene. And all of them causes a lot of problem in the treatment, especially for the doctors. Why there is a delayed wound healing, and how will you know that it is delayed? So let us understand how to know when the wound healing is delayed. The desired healing rate is at least the 50% of the wound area should be reduced within 4 weeks. If it is not reduced up to the 50% of the wound area within 4 weeks, then we say the wound healing is delayed. And what are the causes of the delayed wound healing? There is subtle infection there, especially the osteomyelitis. There is inadequate arterial perfusion and many times inadequate offloading. We will be talking about offloading in the subsequent slides. Understand the difference between wound and an ulcer. Many times there is some confusion what is wound and what is an ulcer. So the old thought is wound was said to be caused by a violence which is usually from outside, such as bullet or surgical incision, whereas the ulcer was usually defined as being caused by some kind of internal etiology or pathology. And what is the present status of definitions? All skin lesions now are called wounds, whether it is diabetic, whether it is venous, it is due to the pressure or surgical fungating carcinoma or trauma. All are now called wounds. Now let us understand what are the causes of ulcers in diabetes. Why does it happen so often? It is mostly due to the neuropathy, nerve is damaged. Partly due to the poor circulation, it is called vasculopathy. There is already high blood sugar or hyperglycemia in the patient and unequal pressure over certain parts of the foot because of certain deformities. Now, when we go for the treatment, we must understand the classification, because classification gives a protocol for all to follow the same way of treating the patients. The most commonly used classification is the Wagner's classification, which is supposed to be on the tip of the tongue of a medical graduate. There are others also, which are usually for the reference, the University of Texas Diabetic Wound Classification, and the third one is Infectious Disease Society of America classification. There are two more. So we must know about the Wagner's classification in details. And it is a simpler one. Grade 0 is there is no open lesion. The foot may have deformities, and this is called pre-ulcerative foot. It is likely to get ulcer in due course of the time. Grade 1 is there is an ulcer, which is superficial one, can be the full thickness or partial thickness of the skin. Grade 2 is now the ulcer has extended to the ligaments, tendons, or the joint capsule, but still there is no deep-seated abscess or there is no bone infection or osteomyelitis. Grade 3 is deep ulcer with abscess, osteomyelitis, or joint infection. And grade 4, 5 both are for the gangrene. Grade 4, it is a localized gangrene in a part of the foot, either forefoot or heel usually. Grade 5 is extensive gangrenous involvement of the entire foot. You can see it, pre-ulcerative lesion. There are deformities which will cause ulcer in due course of the time, but still there is no ulcer. Grade 1, superficial ulcer is present. It is a deep ulcer going to the muscles. Grade 3, the bone has been infected. There is an osteomyelitis. Grade 4, part of the forefoot is gangrenous. And grade 5, whole of the foot is gangrenous. University of Texas Diabetic Wound Classification. It is a reference classification for the diabetic wounds. And it distinguishes non-ischemic wounds from the ischemic wounds and with infection. Ischemic wounds with infection have a higher rate of amputation. So let us see a little of the University of Texas Diabetic Foot Ulcer Classification. Grade 0, pre or post ulcerative site that has healed. Grade 1, superficial wound not involving tendon, capsule, or the bone. Grade 2, wound penetrating to tendon of the capsule. And grade 3, wound penetrating to bone or joint. And within each wound grade, there are 4 stages. Stage A is the wound is clean. Stage B, wound is non-ischemic, but it is infected. Stage C, there is an ischemia, but infection is not there, non-infected. And in stage D, there is ischemia and infection both. There is another one which is also called PDIS classification. P for perfusion, E for extent, D for depth, I for infection, S for sensation. PDIS classification. Now let us see the bacteriology. What are the bacteria that we can encounter in the case of diabetic foot ulcers? If there is a mild infection, usually it is monomicrobial. In case of severe infection, usually it is polymicrobial. Also in acute wounds, it is mostly the staphylococcus which is present there. But in chronic infected wounds, you can add enterobacter as well. Macerated soaked wounds, usually pseudomonas are present there. and the long duration and non-healing ulcers, all of them may be present or part of them along with the fungi. Now let us understand, why is there a deformity in a diabetic foot? It is usually because of the neuropathy. What neuropathy does is, neuropathy causes paralysis of different muscles in the foot, causing muscle imbalance. Also, the neuropathy causes diminished sensation, thereby removing the protection from prolonged pressure at one point. And this prolonged pressure at one point causes microfractures, which leads to deformities again. And what are the deformities? Looks a long list, but if you divide them, it is not long. In foot, in toes, and there are others. So in the foot, usually there are pes cavus deformity, pes planus deformity, and rocker bottom deformity. In toes, there can be hammer toes, mallet toe deformities, claw toe deformity, and the curly toes. And others, Haglund deformity, bunion and bunionette, and the corn and calluses. Let us understand a little of all of them. What is cavus foot deformity? A cavus means high arched foot. They are already a normal arch. When it is exaggerated, it is called cavus deformity. The rocker bottom is when there is a collapse of the longitudinal and transverse arches of the foot. What is the hammer toe deformity? The PIP joint in the hammer toe will be flexed. In the mallet toe, the DIP joint will be flexed. And in claw toe deformity, the deformity is the dorsiflexion of the metatarsophalangeal joint and plantar flexion of the distal interphalangeal joint. Let us understand the bunion. Bunion is a bony bump that forms on the joint at the base of the big toe. And what is Charcot foot? And why does it occur at all? The reasons are following. There is a sensory neuropathy involving the foot that may lead to unrecognized episodes of the trauma, maybe due to ill-fitting shoes. There is a motor neuropathy already causing intrinsic muscle weakness, and thereby a splaying of the foot occurs on weight bearing. And splaying of the foot compounds this trauma. The multiple fractures are unnoticed until the bone and the joint are deformed, and it becomes markedly deformed. And result is a convex foot with a rocker bottom appearance, causing prominence of the bones in the middle portion of the foot rather than the metatarsal heads. The prominence in the middle portion of the foot is then prone to cause ulceration due to undue pressure on it. See it, this is the rocker bottom foot due to Charcot arthropathy, and in the middle portion it has become convex, causing pressure sore here. This is the healthy foot, and see the arches here. The arches has almost reversed. It has become prominent in the middle portion. Now we come to the situation where in Charcot arthropathy there are signs of inflammation. If there is an infection there are signs of inflammation, usually a redness and the warmth. Then how to distinguish between a neuropathic foot and an infection? So the usual way is you elevate the foot for 5 minutes. If the erythema is persisting, it is consistent with infection. And if erythema goes off, it is consistent with Charcot foot. Okay, the Haglund deformity, it is a bump over the back of the calcaneus. Only problem is the Achilles tendon is running over this bump. What are the corns and calluses? Corn and calluses are thick, hardened layer of the skin that develop when the skin tries to protect itself against friction and the pressure. What is the difference between corn and calluses? Corns usually are smaller than calluses and have a hard center surrounded by inflamed skin, and usually develops on the part of the feet that does not bear weight. Examples are tops of the foot, sides of the toes, whereas calluses usually develop on the soles of the foot. You can see it on the top of the foot. There are corns, and now on the weight bearing area there are calluses. Now, what are the factors by which we can predict the wound healing potential in that particular patient? So, factors which has got decreased healing potential, they are uncontrolled hyperglycemia, inability to offload the affected area, poor circulation, infection, and poor nutrition. They are all having a decreased healing potential. What are the factors associated with increased healing potential? It is serum albumin more than 3 gram per deciliter and total lymphocyte count more than 1500 per cubic millimeter. What is the pathophysiology of neuropathy and angiopathy? So, neuropathy has the largest effect on diabetic foot pathology. Sensory dysfunction leads to lack of protective sensation. Also, autonomic dysfunction leads to drying of the skin due to lack of normal glandular function. Whereas angiopathy has the lesser effect than the neuropathy, but more than 60% of the diabetic foot ulcers have decreased blood flow due to peripheral vascular disease. Now, what are the symptoms that the patient may present to the doctors? Let us understand the symptoms of peripheral neuropathy and also peripheral arterial insufficiency, mostly due to these, either one of them or both of them will be there in the patient. So, what are the symptoms of peripheral neuropathy? Hyposthesia, hyperesthesia, paresthesia, dysesthesia, radicular pain, and anhidrosis. And the symptoms of the peripheral arterial insufficiency are, remember, most of the patients are asymptomatic. And when they are symptomatic, usual symptom is intermittent claudication. When it is increases, it can be ischemic pain at the wrist or may develop frank ischemia of the foot. Remember, the claudication of infrainguinal occlusive disease typically involves calf muscles, and in long standing cases there will be calf muscle atrophy. How to do the history taking in a diabetic foot ulcer? We have to understand something about the clues of the neuropathy and what are the clues of vasculopathy, either they are present in that particular patient or not. What are the clues of neuropathy? It could be paresthesia, paralysis, deformities, dry skin, all belong to neuropathy. Whereas the clues of the vasculopathy are pain on walking, it is claudication, can be pulselessness or pallor of distal extremities. When we start the general examination, vitals is to be taken. There is an infection, so systemic temperature becomes important, and the complications of prolonged diabetes, mostly there are two, renal complications and retinopathy is to be looked into that particular patient. Now, examination of the diabetic foot usually is divided in 4 parts. Examination of ulcer, you have to grade it, and detailed documentation is to be given for the ulcer. General condition of the extremity, especially its hygiene, assessment of the possibility of vascular insufficiency, and also a possibility of peripheral neuropathy. We start with the local examination. Inspection is done with the attitude, especially focusing on fixed flexion deformity at the ankle. Swelling around the ulcer is to be noted, deformity is to be noted and documented. Ulcer and its description is necessary. You have to document it, and the details is described in the next slides. Skin for cellulitis. Soft tissues, are they involved? Is it involving the bone of the foot? And lastly, condition of the heel and calcaneal tendon